What patterns do you notice in people who stay healthy, let's say in their 70s and 80s, versus just being medical disasters or chronic health disease conditions at those same ages?
Steve, that is an exceptionally good question. It's a great question. So sometimes there is a little bit of luck involved, absolutely. So sometimes people have been dealt a good hand with their genes, but most often the people that I see that are in great health into later life are people who are taking care of themselves. So they are physically active, they eat well with a whole food, nutrient dense diet, they sleep well, they prioritize their sleep, and they socialize. They have a good family life. They have balance in their life. They are not complete workaholics. They make sure that the stress in their life is mitigated to the greatest extent that we possibly can. So I think often longevity medicine is made exceptionally complicated, but actually it's quite simple. And then the other habits that they do is screening for illnesses early. And that means that they can pick up illnesses before they become really serious or at a stage where they can be treated early. And that means that the treatment is less destructive and the likelihood of survival is that much higher. So I think those are the key things really that make people at a sort of higher plane of longevity than others.
So you mentioned the hand you're dealt. You said that right off the bat, talked about genetics. So whether you're playing cards or whatever else, you're dealt that hand, but it's what you do with it afterwards. Is that how you look at genetics? And can you give me an example maybe of how the hand you're dealt can be affected by decisions you make in life?
Yeah, absolutely, Steve. So the thing is, you can be dealt a bad hand, but you can tilt the deck. You can stack the odds in your favor. And probably the best example of this is my wife, Lucy, who I have the pleasure of working with here in the practice. As I say, it's my name on the door, but she's the boss. So I just do what I'm told around here. I don't know how it is in your neck of the woods. But through the genetic testing that we do in the clinic, a genetic panel testing for cancer, it is super simple, a really easy blood test or a simple saliva sample. We identified that Lucy had a gene mutation called PALB2. PALB2 is kind of the lesser known cousin of BRCA. So it's partner of BRCA2. And it has very similar effects. So it's very similar to BRCA2 in that it increases the risk of breast cancer, it increases the risk of pancreatic cancer, of bowel cancer, of ovarian cancer. And Lucy's mutation meant that she had a 60 to 80% lifetime risk of breast cancer. And we were incredibly blessed to find this out before she developed a breast cancer. And it meant that she could have risk-reducing surgery to reduce her risk of breast cancer. So now her risk of breast cancer is less than 1%, which is incredible. And she gets screened regularly to screen for pancreatic cancer, for ovarian cancer, for bowel cancer, to, again, reduce her risk, to stack the deck, to tilt the odds, so saying.
So that's pretty amazing. So what I'm hearing is, even though this is the genetics you've been dealt, you have two things you can do. One, you can do screening ahead of time and be proactive, and that's looking to make sure things aren't happening. But then two, there's lifestyle factors. Let me ask you this. So you work with patients of all ages, I'm sure. And like these patients that were trying to prevent these genetic things to rear their ugly head, what are the things, like the patterns you start seeing in somebody who's like 30 and 40 that's going to be a big issue when they're 60 and 70? What are those patterns that you see in those patients in the younger years?
Yeah, that is a great question. So you're absolutely right to highlight that, Steve, because often lifestyle patterns are set in those early years of work and family life. And the patterns that I would see are in people who are working really long hours, who often have to commute to work and are in sedentary jobs. So their movement throughout the day is very limited. Their daily step count is limited. Their non-exercise activity thermogenesis, their NEAT, as we would describe it, is very low. They don't have much time to do any formal exercise. And when they do, it's very intense and often very injurious. They are not sleeping well. They are eating processed foods because they don't have time to prepare their own foods. And they have a high amount of stress because here we have a cost of living crisis. Food, energy is very expensive. People are working really hard, and that creates a lot of stress and doesn't lead to a lot of time for them to be proactive about their health and do the things that are really important.
Gotcha. So I know you run a clinic focused on prevention. And what do you think are the biggest health issues you see in your clinic on a daily basis that probably started decades before?
Yeah, that's a great question. So we would have two groups in the clinic broadly. So we have patients who are really keen exercisers, who are super fit. They tend to be the most engaged in doing the proactive healthcare. And for them, when they're coming in, I'm doing more of tweaking their performance. I'm helping them with nuance and giving them really detailed advice. And then we have another group who are working incredibly hard, they're incredibly busy, and health is just completely secondary. And for them, it's about getting the basics in place. And what we really want to do with those people is to try and get them thinking about behaving more like our ancestors. And what I mean by that is adopting the habits and dietary practices that reflect what we have evolved to do. So for me, the most important thing that we do as humans is move. Movement and exercise is a canonical evolutionary activity that is embedded in our genes. It's also embedded in our language. It's embedded in our terms of measurement. So in 1799, the French introduced the metric system, but our more ancient terms of measurement reflected what we did with our bodies. So a mile, mille passum in Latin, is 1,000 paces. A foot is about the length of a human foot. And a stone is about what we could carry in our hands. And my favorite one is an Irish term, the gowl, which is the amount of turf that can be carried between forked arms. So exercise is encoded in our genes, it's encoded in our language, and it's incredibly important because a sedentary existence, which I think of as the collateral damage of modern living, that is the intervention. We often talk as doctors as exercise being a prescription or exercise being the intervention. It's not. It's the normal human condition. And we need to try and do that as much as possible. And what it comes down to is these little tiny engines in our cells, the mitochondria, which are incredibly important for energy production. And the only thing that really makes a demonstrable difference in the health of our mitochondria is exercise. And I think that is the most important thing that we can be doing to preserve our health and longevity.
Yeah, I heard somebody say, I think about myself, I'm super busy and I have to force exercise sometimes. Like, running around the clinic is one type of exercise, but that really, it's movement, but it doesn't really solve the problem, And so I think about that. I heard it say, we live in a world now where, like you said, you almost have to force time to go exercise and move, but that's not what hunter-gatherers did. That's not the way they were carrying everything. They were constantly moving. You had to go get your food. And I think about how our lives have evolved, and you think there were so many years on the planet with that much movement and activity that just naturally came. And now we actually have to force time to get exercise. So I agree with you. I think that's just such a missing piece because I've seen it, and I think you would agree. I'd love to get your thoughts. When people stop movement, whether it be to health conditions, injuries, whatever else, health as a whole takes a tumble. Do you see that? When you lose movement, it seems like everything is off track.
Yeah, absolutely. You are absolutely correct in that. I think that's a really astute observation that you make, Steve. When people are unable to move, so for example, I have a patient this week, and he has had a shoulder operation, and he's in a lot of pain and he can't move. And he is so fed up It's not just the impact physically, it's the impact mentally as well. He's a guy, he loves exercising, he loves going to the gym, he loves getting out and running, but everything is on hold. So it has a massive effect on our mood. It has a massive effect on our metabolism. It has a massive effect on our muscles. And we know that muscle mass and strength are crucial to longevity. And if we are unable to engage those muscles, they will atrophy, they'll waste away. And that has a tremendous deleterious effect on our overall health.
Gotcha. So we've mentioned muscle. So I know that's a hot topic right now. There are a lot of people out there treating muscle as an organ. I mean, I don't think about that. I just thought that's what it made you move, but you mentioned mitochondria. Tell me why you think muscle is such a powerful marker of long-term health in terms of a patient's age and maintaining muscle as we get older.
That's a great question, Steve. So the three things that I think about when it comes to muscle that are really important. So firstly, we think about muscle mass, and then muscle strength, and then muscle power. Muscle power is the one that doesn't often get a mention. But muscle power is absolutely crucial to living a longer, healthier life. And the reason being is that as we age, we preferentially lose type 2B muscle fibers. And these are the muscle fibers that are responsible for force generation. And if you think about it, these are the fibers that are engaged when we need to do a sudden movement, like preventing us from falling. And it's really important to engage those muscle fibers when we are in our 30s, 40s, 50s, and 60s, and we can gain muscle in old age. And even in old age, if you haven't exercised, now is the time to start. It's like that old, I know it's a bit of a cliche to say it, but it's like that old Chinese proverb, the best time to plant a tree was 10 years ago, and the next best time is today. So it's never too late to start. And we know that muscle power is very important. As I mentioned, muscle mass is crucial to longevity. And the reason is this, that at a time of crisis, such as an illness, when we're admitted to hospital or an operation, we need those reserves of protein to tap into to help with healing and to help with recovering. And then muscle strength is also crucial to longevity. And we know from studies of thousands of people that this is the case. So all of those factors are really important to train as soon as possible and to try and maintain throughout life.
So you brought up something I find interesting, and this is a challenge. So we get patients that we start on this wellness journey or longevity journey later in life. They maybe didn't take advantage of those 30 to 40 years, but they're 50, 60, and 70. What type of exercises do you feel is someone that's in their 50s and 60s can comfortably do to maintain muscle other than just walking? Because you and I feel like that's like the thing. It's like, oh, I walk, I get my 10,000 steps a day in. But that doesn't quite cut it because we need to move more. What are the things somebody who's maybe said 50 to 70 that you feel like is good that can build muscle that they are actually capable of doing?
That's a great question, Steve. Always the question I ask people when I'm in the clinic room is, what do you enjoy doing? What exercise do you enjoy? Because if you're going to hate it, it's not worth it. And often that exercise, may be really great for longevity. So we know that the best sports for longevity are racket sports, particularly tennis. And there's all sorts of reasons for that. It's high impact. It requires a lot of coordination. It's highly social. There are obviously confounders in that it tends to be wealthier populations who play tennis. But it speaks to the fact that there are other factors involved. So if there is a sport that you love, play that and train for that. So if you love golf, train like Rory does. Train like Rory McIlroy. Rory McIlroy is deadlifting in the gym with a hex bar because he knows it improves his golf swing. He is getting out and doing his zone 2 exercise because he knows it will help him, in the, on the walking to the 18th green at Augusta, because he will have the exercise capacity to be able to nail his putt. If you love tennis, then train like Novak. If you love dance, train for that. So I think the most important thing is to do something that you will enjoy, and try and be as good as it, and get as much enjoyment out of it as you possibly can. In terms of what, for example, which I think is what you're more asking about, like what exercises can people safely do? It sort of depends a lot on the individual, but I really try and get people, where possible, if they can manage it, to focus on compound movements, which are multi-joint movements, and we want them to be functionally useful. So I always talk about getting people to do squats, and this can be as simple as doing an air squat. And because squats are very useful to get up and down from sitting. And I talk to people about doing lunges, because they can do that. And that is very important for getting up and down stairs to maintain independence. And I talk about shoulder press, because it's useful to take things like, like books off shelves. And we talk about being able to do press ups or push ups, because you can push yourself off the floor in the event that you fall. And we talk about doing deadlifts, because it helps you pick things like grandchildren off the floor. But we can adapt those, and those are all exercises that can be easily adapted to the person. So for example, everyone is terrified of deadlifting, but you don't have to deadlift with a heavy bar. It can be a single leg deadlift with absolutely no weight, and that is challenging for your balance. And these are exercises that can be progressed over time. So it doesn't have to be complicated. And often with my really busy patients, so we'll have lots of busy patients who work in the City of London, and they might be in finance, they're in banking, and they have no time. And I say, can you give me 1 minute of your day? And if you could just try and do 1 minute of air squats on one day, and the next day do 1 minute of lunging, and actually doing 1 minute of any of those exercises is actually quite tiring. And I do a lot of exercise. And even when we finish this podcast, and I'd encourage everyone who listens to this podcast, when they finish, to go and do 1 minute of air squats, and they'll be out of breath. So it doesn't have to be perfect. You just have to do it. And going back to what I was saying about the power, a great way to incorporate power into that is what's called complex training. So complex training incorporates doing a heavy lifting kind of motion, but it doesn't have to necessarily be heavy. So you could just do maybe 1 minute of air squats, and then you could do 10 squat jumps, and that's amazing for power. Or you could do 1 minute of lunges, and then maybe you could do some lunge jumps. Again, amazing for power. So those kind of ballistic rapid motion, if you can do it safely, they're really good for developing power. And I think, when it comes to exercise as well, and exercise, longevity, and performance, it's really good to have a plan. So having a professionally done plan, and obviously there's lots available from really good resources online, but having a plan is associated with much better exercise outcomes, and people are much more likely to stick to it. And exercising with people as well makes a massive difference to how well people do and the effort involved. So if you can exercise in a group, all the better, because you won't feel as though you're working as hard.
And I think that's great. You mentioned find something you love. Like, I have to admit it, I used to hate lifting weights, but now that I've started doing a little more of that and I see progress, I'm like, oh, I need to do that more. So let's talk about that. You're right. Everybody don't have it. Nobody has enough time nowadays. You mentioned that you work with a lot of patients that have jobs and don't have a lot of time. What I see a lot more out there about like high intensity interval training or sprint training. And I'm not here to say that's for everybody, because you need to check with your healthcare provider first. But is the data that's on that you kind of get more bang for your buck than just out walking? Is there enough data to really say that's a way, if you're limited with time, you make it, get that in and make that? What are your thoughts on that?
Yeah, Steve, you're dead right there. So high intensity interval training is the most efficient way to improve both your cardiorespiratory fitness and your cardiovascular health. And we know that it can have tremendous benefits on people's lipid profile. It can have tremendous benefits on their blood sugar, and it can really quickly help improve their VO2 max, which is a very accurate measure of people's overall fitness. So it's a really time efficient way to improve cardiovascular health, I think. And it, obviously, as you said, really important to check with your healthcare provider first that it's suitable for you. And it's still really important to do a warm up, an activation of the muscles and cardiovascular system, and a cool down afterwards. But it's a great way to do things pretty quickly. And often people will get obsessed about doing. They have to do like a full hour of something. It doesn't have to be like that. Anything is better than nothing. If you can squeeze in one minute of something or 2 minutes of something, do that. It doesn't have to, it doesn't have to be, all out. We don't have to get the full running gear on and go for a really long run or get it like, I'm one of these guys who loves to, go out and cycle and wear Lycra and spend hours in the bike. Doesn't have to, it doesn't have to be getting the full kit on. You can just do little bits throughout the day if that's all you have time for. And that really works well.
So for you, you kind of mentioned, so patients who get older, get sedentary, I mean, we lose muscle pretty fast as far as that goes. What is like your prescription to say, hey, these are the 2 to 3 things you need to be doing to make sure that you maintain that muscle and we prevent that sarcopenia later in life? What are those? Yeah. What's your outlook on that?
Yeah, great question, Steve. So the resistance exercise, of course, is crucial. And the thing I would say with that is that it doesn't have to be loads as well. So there is very good evidence from a big study in Dallas, actually, that even one resistance training session a week makes a big difference. The evidence seems to point to the optimum for longevity, rather as opposed to for performance, but for longevity, 2 sessions a week of 30 to 60 minutes seems to be fantastic for longevity. So resistance exercise, very important. Doesn't have to be lifting really heavy weights, or as we would say another mad tin. So it doesn't have to be huge weights. It can be resistance bands. It can be body weight, and make it fun, make it enjoyable, make it in a group. And then the other important thing to prevent sarcopenia and to help build up muscle protein synthesis are having sufficient protein in the diet. So this is an exceptionally contentious issue in medicine at the moment that seems to be the subject of lots of rancor and wailing and gnashing of teeth. I feel that I think the most rigorous meta-analysis on these seem to show that having 1.6 grams per kilo of body weight per day is the optimum for muscle protein synthesis. Some people argue it's a little bit less at 1.2, and there are some studies in people who are older or more prone to sarcopenia that up to 2.2 grams per kilo body weight is useful. And obviously it's slightly different for competitive athletes, but I always say everyone is an athlete. So at least everyone should be aspiring to be.
I love that. I love that. Of what you're saying. Everybody needs to think like that, because if not, you're going to end up going the wrong direction.
Exactly. So eat, exercise like an athlete, eat like an athlete. So I would tend to advise people to go for 1.6 grams per kilo body weight of protein, and getting really good quality protein is really, really important. So we really advise having a whole food, nutrient dense diet to achieve that. And then the other important sort of extra bit that I might advise people to have, if they're suitable, is to get them to take some creatine, which again is another very, very hot topic at the moment. 3 to 5 grams, I don't tend to go for these massive doses. Seems to work really well for muscle protein synthesis, provided, of course, that the person is doing some resistance exercise. That is the key thing. And I think that is useful to enhance muscle strength, muscle mass, because it essentially helps with the energy production of the muscle cells so that you are able to lift more and lift for longer. And that helps you become stronger and get bigger muscles. That's why
you must have my questions, because I was going to say, hey, what's one supplement you'd recommend? And creatine was that, as far as it goes. So is there any, like you mentioned, you're right, I'm seeing all kinds of stuff from brain function at crazy high doses and different things, and as far as that goes. But is there, so I assume, one, you recommend it to your patients, and if so, is there any misconceptions about creatine that you're right, it's so widely, I mean, it's probably one of the most studied supplements there is.
Yeah.
Is there any
Yeah.
misconceptions that you kind of feel like need to be kind of squashed or taken care of so that people don't have to worry about taking creatine?
Yeah. Well, I think the biggest misconception, which has been for a long time, probably you'll have known about this for years, is that it is damaging to the kidneys. And I think taken in appropriate doses and in the right way, there is really good evidence that it isn't harmful. But I think it should be taken, in the appropriate doses. One of the reasons why doctors sometimes worry about it in relation to kidney function is that, and you will of course know this, Steve, is that creatine is broken down to creatinine, which is the marker that we use when we're checking people's kidney function. And that is used in a measure called eGFR, which is essentially how well the kidneys filter the blood. Now, if someone is taking quite a lot of creatine and they're exercising, which will cause muscle tissue breakdown, that can artificially elevate their creatinine levels. And then doctors get in a bit of a panic that their renal function is abnormal. Now, there's a little way around that. There's a slightly newer test called cystatin C, which is a slightly different mechanistic way of measuring kidney function. But often I will tell my patients, if they are taking creatine and we're going to check their renal function, to stop the creatine for 72 hours beforehand and also chill out on the exercising a little bit as well, just so that they're not having a lot of muscle tissue breakdown, because that can also artificially elevate the creatine. So I think that's the main myth around it that I'd say. You make a very good point about its impact on cognitive function. So there have been studies, particularly in older adults and also in people who are sleep deprived, that it can help improve cognitive function following sleep deprivation. So I think there is that usefulness as well.
That's great. Thank you for sharing that. I think those are some great tips. I do a lot of social media, and that is the number one question. Well, I thought it affects the kidneys. And so you made that very, very clear. Great talk. So you mentioned exercise and how it affects markers that I know you like to track in your practice. So just as a starter, what are the health markers that you wish more doctors tested earlier?
Oh, what a great question, Steve. I'm going to tell you that the one that I really wish more doctors would test is lipoprotein(a). So we're perhaps a little bit obsessed with lipoprotein(a) here, and I'm sure Lucy won't mind me disclosing to you and your entire audience that she also has been dealt a bad genetic hand when it comes to lipoprotein(a), because she has the highest levels of any woman that we've checked in the practice as well. So when we talk about being dealt a bad genetic hand, this is it. So what is lipoprotein(a)? Well, lipoprotein(a) is a cholesterol-containing molecule, and it is, as we would term it, highly atherogenic. So that means that it can very easily go into the wall of the artery, where it causes a big inflammatory reaction. It's a very sticky molecule because of its structure, and it causes an inflammatory reaction in the wall of the coronary artery and really accelerates the risk of heart disease. And it is really important because it is 95% genetically determined, and the increasing levels increase the risk. And it's incredibly important to identify early, because if we identify it early, it means that we can be much more aggressive in reducing people's other risk factors for cardiovascular disease. And that's why it's so valuable to check. Now, some people will argue and say, well, at the moment, there is no treatment that can really bring down lipoprotein(a) levels. And that is true, although there are several trials ongoing in medications that can, we know, safely lower the levels. And the key question is, does that save people's lives? That's the most important outcome. So that those trials are awaiting publication, and I think will be coming out soon. But in the meantime, when we identify someone who has elevated lipoprotein(a), it is really important that we manage all their other risk factors. So what does that mean? Well, it comes back to the things that I've been banging on about. It comes back that they should be exercising to help reduce their non-HDL or their ApoB. They should be sleeping well. They should be socializing. They should be eating well. they should have perfect blood pressure, which I think is probably the most overlooked longevity biomarker. I mean, people are incredibly bored by blood pressure, and yes, it is very important. There are other much sexier metrics like HRV and sleep scores and recovery scores. But I much prefer someone to have a perfect blood pressure than a perfect recovery score. So having perfect blood pressure, not smoking, having normal visceral fat. So visceral fat is the fat around our organs that massively increases our risk of cardiovascular disease and diabetes and of certain cancers. So we can check that very quickly in the clinic by waist to hip ratio. But some of our patients will have a body composition done by MRI that will actually look at the visceral fat and give us very detailed and accurate measurements of that. So all of these risk factors can be addressed to really reduce people's risk from an elevated lipoprotein(a).
So I myself have an elevated lipo, and I agree with you. And so, believe it or not, I have been able to reduce it with some supplementation. It's the low end of the high, but the thing is, but you're right. It's one more important factor. So I know you like to take a deep.
Using some
What's that?
omega fish oils with that.
Of course, to me, that's almost a non-negotiable. I would say supplement as long as it's good quality. To me, omega 3s is almost a must. So
and we've had a few patients who it's made a big difference in bringing their levels down.
Yep. So I know you have a lot of passion for cardiovascular biomarkers. So you mentioned lipo(a). When I was taught in pharmacy school and traditional training, I don't know about over in England, but it was like, you check the total cholesterol. And I think there's some value in there, LDL and HDL and triglycerides, especially triglycerides, because I think that's a marker of excess. But what are the other, I would say, cardiovascular markers that you like to look at in terms of preventing cardiovascular disease? Because no matter what you do, cardiovascular death, at least here in the US, is still the number one cause of death. So what are the big cardiovascular markers you like to look at outside of lipo(a) that are things you like to look at?
Yeah, and it's much the same over here in the UK. So 25% of deaths are due to cardiovascular disease. So one of the other metrics that I'm really keen on testing is apolipoprotein B, which I'm sure you're very familiar with. But I suppose the best way that I would describe this is that essentially that the cholesterol in the body is all the same. It's all the same molecule. There is no good or bad cholesterol. It's how it's packaged is important. And the traditional cholesterol tests, which are checking for LDL or non-HDL, they're checking the mass concentration of cholesterol. And the more important metric is the number of cholesterol-containing molecules. And the way we measure that is through apolipoprotein B. And I have this rather absurd analogy that I tell patients, and we'll see if it travels across the water. But I think of cholesterol molecules as being very much like people. They are all the same. And like people, they hang around in groups. And I think of the HDL as being like groups of cruise ship tourists. So if you can imagine that the arteries are like streets in a city, and that the lining of the arteries are like bars and clubs along a street. And cruise ship tourists, when they get off their cruise ship, they don't really go into the bars or clubs. They just wander around, and they're usually taken around by a tour guide who's holding a little red or white flag and takes them around the city. And in the body, that tour guide that's taking the cholesterol rounds is apolipoprotein A if it's a HDL. Now, the LDL is a little bit more like a bachelor party. So they also wander around the streets, but they want to get into the bars or clubs. Now, I don't know as much of what it's like in the US, but in Europe, it's very difficult for a group of 20 guys to get into a bar. So what happens is that the best man will hire a tour company to get them in past the bouncer on the door. So they'll get a tour guide, and their tour guide in the body would be like apolipoprotein B. That gets them past the bouncer on the door and gets them into the bar or club. And that's essentially what happens in the body. The cholesterol containing molecules that can get into the wall of the artery, get in there, and they cause trouble once they're inside. So apolipoprotein B gets the cholesterols into the wall of the artery and then all hell breaks loose. That's basically what happens. It's like when a bachelor party gets into a bar. But if they didn't have that apolipoprotein B, they wouldn't get in there. That's the way to think of it. Now, the other important thing of why apolipoprotein B is so important is that if you think about a bachelor party, well, no bouncer is going to let in a massive group of guys. And it's the same with cholesterol. So some people might have a very high traditional LDL level, but actually their ApoB level is relatively low because they've got lots of big particles. And they're not going to get into the wall of the artery quite as easily. But if you have lots of small particles, that's very dangerous. And that's where ApoB can offer a little bit more nuance. And it's particularly important because in certain conditions like diabetes or metabolic syndrome, the LDL can be an underestimate of risk. And that's to do, Steve, with what the word that you mentioned earlier is the triglycerides. And it makes the traditional way of measurement a little bit harder to interpret. So that's why, to me, ApoB is so important because it gives a much more accurate measure. And it's also a really important target for treatment as well. So I really like measuring ApoB. And then in certain groups as well, we will be measuring highly sensitive CRP, which I'm sure you know all about. And that is about really thinking about the additive risk of inflammation. And inflammation is a key driver to atherogenesis. So I'm more likely to be more aggressive in my management if someone has an elevated, highly sensitive CRP above 3. So that again adds a little bit of nuance to the information that I get.
So is there any other like 1 or 2 markers outside of these cardiovascular markers that you think are the critical markers to promote longevity in a patient?
So I think in terms of cardiovascular disease, the other things that I'd be thinking about is in terms of metabolic health. So I'd be thinking in terms of people's fasting glucose, their HbA1c. So HbA1c, I think, is incredibly valuable. It's so useful to check. So HbA1c is essentially sugar attached to hemoglobin. And hemoglobin has a turnover time in the body of about 8 weeks. So it tells me what someone's blood sugar has been like over the preceding 8 or 12 weeks. So they can't game this test in any ways. Now, there's a few subtleties that are important to remember in hemoglobin. So if someone has an abnormal type of hemoglobin or has an abnormal amount of hemoglobin itself, that can affect that result. But so where the hemoglobin level is normal, it's an incredibly useful and valuable test. Often we'll be using fasting insulin as well to see how metabolically healthy people are. And the reason for doing those tests is because having metabolic disease, having metabolic syndrome, and having diabetes are key drivers, key accelerants of cardiovascular disease. And this is really gives us an opportunity to get in early and take ameliorative action as soon as possible.
Those are great. I love your cardiovascular cruise ship analogy. I may steal that one, so I hope you don't mind that as far as that goes. So
please do.
that is very good. So you've talked about cardiovascular health, you've talked about metabolic health, you talked about exercise. To me, there's one other thing, especially, and I see this in a lot of our male patients, and that is hormone replacement. I'm just seeing guys with different testosterone levels. They seem like they do all the things right, but they still don't feel good as far as that goes. And I know a lot of guys, they just really stay away from the doctor. I hate to say it. That's just the way most men are. We stay away. Why do you think most guys are reluctant to stay away from care in terms of medical care versus, like you said, our female patients that I feel like are a little more bought in terms of this longevity side of stuff?
Yeah, I think you're absolutely right in that. In fact, often the driver for the guys to come in is because they've been told to come in by their wife or their daughter or their mom or their aunt. So it's very often the female who's driving that. And I think, I still think that there's a culture amongst men of just putting up with things and getting on with it and not wanting to to ask for help or to appear to ask for help. And I think that's been changing a little bit, but probably not enough. So I think there is a little bit of men just trying to, get on with things and ignoring symptoms. That's ultimately unhelpful, because, if you want to be the guy that is a loving husband or partner, that is a loving son, that's a loving father, you need to look after your health, because you need to be in the best possible health to be able to provide for those around you.
No, that's good. So what do you see usually gets that man into the clinic? What do you think usually gets them there finally, that they're like, okay, I got to go? What are those things you think are the most common?
Yeah. So two things really. One is the prod from a woman in their life, and the second is a scare in a friend or a colleague. So the number of people that I would see who come in and tell me, oh, their boss was diagnosed with bowel cancer, or their brother was diagnosed with prostate cancer, or they were playing tennis the other day and one of the other people told them that another guy that plays tennis had a heart attack. That would be the kind of thing that triggers them to come in, and they'd be like, okay, I need to sort myself out now. And I'm like, good, it's about time. Thank you for coming in.
That's good. So testosterone is a hot topic right now for men, as far as it goes. So what are the myths that you see around testosterone and men's health that you kind of wish would get cleaned up, or if you have your thoughts on?
So testosterone is a fascinating space at the moment, and it's really interesting because I feel that that hypogonadism or testosterone deficiency is both simultaneously over and underdiagnosed, which seems absurd, but it's essentially because people who are very fit and go to the gym, who work out a lot, lift weights, are often acutely aware, because of what's presented to them socially or what's presented to them on social media, about testosterone deficiency. And so I see a lot of really fit guys where we live in London. There's a lot of social media influences. So we live in an area called Parsons Green. It's like the mecca of social media influences. So everyone's really ripped around here. They're in great shape, and loads of them are worried about their testosterone levels. And there's absolutely no need for these guys to be worried about their testosterone levels. But they've been told online that so many people have testosterone deficiency, and yet there is this other group, and it is men who might be diabetic, or might have chronic pain, or might be suffering from depression or anxiety and taking SSRIs. And it's in that group, or men with chronic illness, that group where often they have testosterone deficiency. And it's often the case that the people who need it least are checking for it, and then no one is thinking to check it in the people who really need it. And we know, for example, that in men who are pre-diabetic, who are testosterone deficient, if they get testosterone replacement, they are much less likely to go on to develop diabetes. So it's really important to recognize and to treat in the men who need it. And I also think it's really important that it's not treated in the people who don't need it. And I think there are plenty of ways to help optimize our energy and our life without people having to resort to taking testosterone when they have normal testosterone levels in the first place. And obviously there's a lot of nuance around testing, but and in terms of the symptoms. So what are the symptoms that people should look out for? Well, lack of energy, lack of libido, lack of morning erections. They're the really key symptoms. Lack of zip, lack of drive. Testosterone is a hormone that acts on tissues all over the body. People think about it as a hormone that is just for the gym and the bedroom, and that's not the case. It's a really important hormone for tissues all over the body, and it's really important to recognize it. And then when it's tested, ideally we want to test it with people fasted and before 11 a.m. because we want to get it at the right time of right time of day. And that testing is really important. And then the other thing is that's important is that, like a lot of hormones, it's important to, they can be impacted by lots of things like external stress, or if someone's had an exhausting weekend, that we shouldn't be just taking it on just one reading. It's really important to confirm the diagnosis by taking a second reading. And I think some of the things some of what's happening online, or with some more unscrupulous online providers, is that they are doing the testing in a way that isn't truly rigorous, and leading some men to think that they have testosterone deficiency when they don't, because the test has been taken at the wrong time of day, or the test hasn't been confirmed properly, and then they end up taking testosterone when they didn't need to.
That's good. So in your opinion, like I saw a study not that long ago about US, the average testosterone level for a man at a certain age is dramatically less than it was like in the 1940s, 1950s. Do you think this is more related to lifestyle or just aging differently? What are your thoughts on that?
Yeah, I think it is predominantly related to lifestyle, and also a bit the environment as well. And I'm no means an expert on environmental toxins, but I'd say that is a likely element of it. But I also think probably that the main driver is when I talk about the environment, is actually that the environment has made our lives easier than it was for our ancestors. So our environment is designed for comfort, and that isn't entirely reasonable. Like Dan Lieberman argues that we didn't exercise because we wanted to. We exercised out of necessity. And that's why we have all these inventions that make our lives easier. But actually, they're doing us a disservice. And the factors that I think are really driving this is that because our environment actually makes it quite difficult to exercise, it's hard to find the time because everyone is working so hard. And then people are sitting in sedentary jobs, and they're eating very hyper palatable, readily available food. So they put on weight around their middle, and they develop what we term central adiposity. So they develop fat around their organs. And as a result of that, testosterone levels are much lower than they would have been years ago. So I think those are the main factors, in my opinion, Steve.
No, that's good. So just kind of wrapping up, I have a question for you. So you deal with a lot of longevity. You look at people, and you mentioned influencers earlier. I mean, there's no lack of information about quote unquote longevity and wellness as we get older. What's the one thing you think people obsess about the most that probably moves the needle the least?
Wow. Where to even begin with that, Steve? I mean, there's I think it's to your point. It's getting lost in the noise. It's getting lost in the weeds of these. And I think probably these a lot of the health metrics that people are tracking. So people are tracking lots of different metrics that aren't particularly important or valuable. I think often doing quite a lot of very sophisticated tests without thinking about the basic tests first, like simple things like blood pressure. So I think it's all about parsing out the really important stuff, and the important stuff isn't as seductive as some of these new fancy tests or metrics that come along, but they remain really important, and those are exercise, sleep, connection, eating well, and testing for chronic illnesses early.
Very good. This has been great. I've really enjoyed this. You have a lot of real world experience working with patients to achieve the best health and longevity they could have. If people want to learn more about you, where can they find out about you and your practice?
Oh, thanks so much, Steve. It's been such a pleasure coming on. So I'm actually on social media, despite me ranting about it. So I'm on Instagram and TikTok at Hugh Coyne, and also we have plenty of blogs and content on our website, which is coinmedical.com. And we have just started our own podcast recently, which is the Life Podcast. So you can hear more about me rambling about bachelor parties and cruise ships then.
I love that. This has been great. Like you said, I appreciate you sharing your insights on prevention and biomarkers and just simple habits that people can make to help improve their health long term. And I think hopefully if people connect with that, they can share it, because there were so many practical tips you brought today that I think the audience is really going to enjoy. And I really appreciate that.
Oh, brilliant. No, thanks so much, Steve. I really appreciate it too. Thanks for having me on.
Thank you.